Now we will start our second session with Dr. I'm sorry for the how to spell or how to say your name. Yeah, excuse me, Giuseppe Campanini. Yes, it's okay, very good. He's a senior consultant in the European Institute of the Milan. The presentation will be on the challenges of the treatment of the early triple negative breast cancer.
Use also this. Okay. Thank you. Thank you from the deep of my heart for your kind invitation, for this great opportunity. It's a very honor for me to be today here with you. So the topics of my presentation are challenges in the management of early stage triple negative breast cancer patient. Triple negative breast cancer is a particular subtype characterized by the lack of estrogen and progesterone receptor and the absence of HER2 amplification or hyperexpression. Is a very composite disease. The genomic landscape is currently under discovery. In Europe, the mainstay of the treatment for this patient is the backbone of neoadjuvant chemotherapy, with a special issue for the special subtype like secretory carcinoma, low-grade metaplastic carcinoma, or adenoid cystic or apocrine carcinoma that have an intrinsic good prognosis. So attention when we prescribe neoadjuvant chemotherapy to the histology. We know, as mentioned in the previous presentation, the great value of complete pathological response to neoadjuvant chemotherapy. And many efforts were done to improve the rates of pathological complete response. We know that nowadays these rates range from 30 to 50% with the common use schedule of chemotherapy. So, the important rationale of combining immunotherapy with chemotherapy in 2017 was launched a landmark study, Keynote 522, that was a randomized phase 3 international study that enrolled about 1,200 patients with triple negative yearly breast cancer with aggressive feature. And randomized to a backbone of anthracene taxane chemotherapy, and of note, during the taxane phase, there was the aging of carboplatin both in placebo and pembrolizumab arm. So this is a very strong backbone of the chemotherapy, consisting of 12 weeks of carboplatin paclitaxel plus or minus pembrolizumab, followed by 4 cycles of epidoxorubicin and cyclophosphamide given every 3 weeks, then surgery, and regardless the pathological response, an adjuvant phase with pembrolizumab until 9 cycles versus placebo. The primary endpoint was rate of complete pathological response, but of note in this trial, the design was powered to detect an advantage in event-free survival. And this is an exception, because the most number of neoadjuvant trial are powered only to detect the benefits in terms of pathological complete response. This is the population included. We know that there was a balance between placebo or pembrolizumab arm, and this is the first results. We can see that the study is positive. There was a benefit in improve the rate of pathological complete response from nearly 50% to 65%. But of important, we know that at the first interim analysis, and significant benefits in terms of event-free survival. And we can see that they improve is independently by PDL expression, but we know that PDL is a predictive, a positive predictive biomarker of pathological complete response, both for chemotherapy and for the chemotherapy plus pembrolizumab. At a new in the interim analysis after a follow-up medium of 39 months, we see a very meaningful benefits in terms of event-free survival, with a gain in absolute terms of 8.1%. In this first plot, we see that the benefit is represented in all subtypes, and important for us that are medical oncologists, we see positive results both in positive or negative patient, in stage 2 or stage 3 patient. Overall survival analysis are not mature at this time. More efficacy as a cost. The cost is more toxicity. The common toxicity are not more in the pembrolizumab arm, and of important also in the adjuvant phase. But immune-mediated adverse are obviously more frequent in the pembrolizumab arm, and I want to take a point to adrenal insufficiency and hypophysitis, because are life-threatening possible adverse events. So in Europe, ESMO, our society, recommends the blood cortisol monitoring at the baseline and prior the surgery. In this slide, we see that like ESMO suggested to manage these adverse events. And on May of this year in Europe, there was the approval of this treatment. And now in my institution, this is the standard of care. Consistent with previous results, also in patient 031, sought a benefit of adding atezolizumab to neoadjuvant treatment. We saw that in this study is lacking carboplatinum. The schedule is dose dense, and there is not paclitaxel but nab-paclitaxel. the results are the same in terms of benefits in pathological complete response. And also in this study, we see that PDL is a positive predictive response of benefit to chemotherapy or chemotherapy to plus immunotherapy. This is a very important slide according to my opinion, because we can see that if I have a patient with node involvement, the association of chemotherapy plus immunotherapy highlights to the same rate of complete response after the treatment. This slide resume the most important study done in this field. We saw that every time we adding ICI, an immune checkpoint inhibitor, we saw at least a numerical improvement of pathological complete response. To nowadays, only Keynote and Gepard-Nuevo have demonstrated an advantage also in terms of event-free survival. It's all clear? No. We are unanswered questions like what is the optimum duration of immune checkpoint inhibitor in case of PCR, or we can identify a group of patients who will do well with chemotherapy alone. All patients have to receive immunotherapy, which is the optimal backbone of chemotherapy, and which is the optimal post-neoadjuvant chemotherapy if a patient does not achieve complete pathological response. Some insight we can give by Gepard-Nuevo. This is a smaller study, a phase 2, in which durvalumab, another immune checkpoint inhibitor, was given for 22 weeks in the neoadjuvant fashion without the adjuvant setting. We see that there was numerically but not statistically improvement in terms of pathological complete response, but at 3 years of follow-up, we have significant clinical and statistically benefits in terms of overall survival and event-free survival. In this slide, we can see that are very similar, the results with only 8 cycles of durvalumab plus neoadjuvant chemotherapy versus like 1 year of pembrolizumab given in neoadjuvant and adjuvant setting. What we can say, it's safe to forgo adjuvant pembrolizumab for the patient who achieved the pathological complete response. It's reasonable to think to briefer neoadjuvant immunotherapy exposure. There is another study that is in phase of launch in USA. The principal investigator will be the Professor Tolani. Optimize will answer if is of benefit adding pembrolizumab for the patient who have achieved pathological complete response after neoadjuvant chemotherapy. Alternative neoadjuvant regime for triple negative breast cancer are composed by the association of carboplatinum plus docetaxel, like we can see in the little study NeoPact. Also study just published is NeoStop, and a special mention in my opinion, is for sacituzumab govitecan, that is an ADC, so an antibody drug conjugate, now approved for advanced phase, that shows in neoadjuvant phase significant benefit in triple negative breast cancer. What we can say for the patient who does not achieve a pathological complete response, we know that the standard for now is capecitabine. According to the data of CREATE-X, ECOG 1131 was a study that sought to investigate the adding of platinum agent in adjuvant setting instead capsid, but the results are negative. So the standard of care now is ever capecitabine, and for the BRCA mutated patient, Olympia trial demonstrate a significant benefit in terms also of recurrence-free survival, adding in adjuvant setting olaparib, that is a PARP inhibitor. There is a role for pembrolizumab post neoadjuvant chemotherapy for patient with residual disease. This is the answer. This is the question that will be answered by SWOG 1114. Is an ongoing trial, and we are waiting for the results. But in this field, we have also SASHA trial, that is a post-neoadjuvant trial with an ADC, sacituzumab govitecan, versus a treatment of physician's choice that could be capecitabine or platinum, and a potential future trial that is ongoing, designed in Alliance and NCA, is a trial that that will randomize patient to an ADC like sacituzumab govitecan, an ADC plus pembrolizumab, or pembrolizumab plus capecitabine. That is the standard of care. Another trial ongoing is Geparduz, is a neoadjuvant trial, and we can say that is the twin trial of Keynote-522, but is different the immunotherapy agent used, because in this trial we will use the atezolizumab instead pembrolizumab. The results are waiting. At least the inpatient trial 030 is an all-adjuvant trial. This trial is available in our institution that randomizes the patient with stage 2 or 3 triple-negative breast cancer to chemotherapy, to adjuvant chemotherapy plus placebo, or chemotherapy plus atezolizumab. This slide resume the most important trial ongoing or that are completed enrollment. So in conclusion, we can say we have done significant progress in the management of early stage triple negative breast cancer. Neoadjuvant therapy is the preferred for all patients with a caveat for the smallest tumors. PCR is associated with a markedly improved outcome and allows to individualization to customized therapy with the response. Immunotherapy is now the standard of care, adding to neoadjuvant chemotherapy. We have to understand who needs immunotherapy, and we have to manage better the toxicity related. So this is my proposal of an algorithm for the treatment of high-risk early stage triple negative breast cancer. We have said that the mainstay is neoadjuvant chemotherapy plus pembrolizumab for now. For the patient who achieve pathological complete response, the standard of care for now is complete 1 year of adjuvant pembrolizumab. For the patient who not achieve a pathological complete response, if there is a mutation of BRCA, I consider the concurrent administration of olaparib plus pembrolizumab, or my favorite choice is for olaparib. If there is not a germline BRCA mutation, I consider capecitabine plus pembrolizumab. Thank you for your attention.
Thank you so much for this eminent talk. Yeah, really, we enjoyed. You got for us all the trial. Personally, I have a question, but first the floor is open for questions. I want to ask, what's your treatment plan or your treatment algorithm if a high-risk early triple negative breast cancer with BRCA mutation? She came to your clinic, she is high risk and she is BRCA mutant before treatment.
Okay, we know that the germline BRCA mutation is not a predictive biomarker of benefit of adding carboplatinum in a neoadjuvant fashion. Because of the results of brightness that investigated the adding of PARP inhibitor, that is veliparib plus carboplatinum in triple negative early stage patient, and there is a sub-analysis that show no improved with the association that show that the improve in terms of pathological complete response is independent by the BRCA mutation. So is not an inform for me to choose a neoadjuvant backbone of chemotherapy. I treat a patient mutated, BRCA mutated, likewise a patient no mutated in terms of chemotherapy. The standard in our institution for stage 2 or 3 is the adding pembrolizumab. The conundrum is if the patient do not achieve pathological complete response, because in the keynote 522, olaparib, adjuvant olaparib was not allowed, because we have not data of adding pembrolizumab to olaparib. So is a physician show, is a physician decision. And my suggest is to prefer olaparib, cioè a target therapy in adjuvant setting for this patient. But if it's possible, and if the prognosis is worse, maybe because the residual cancer burden is high, I would consider to escalate the treatment in adjuvant setting, adding pembrolizumab currently, or with a sequence administration. We have a patient followed in our institute that we have treated in this way.
Thank you so much. Professor Hebel?
Thank you very much for being with us today. I thank you for very demonstrative presentation. I have visited Milan several times and I like it more than Rome. I go to Lugo Maggiore. And it's a very nice place. Yeah, I hope I visit your center.
I hope to see you again in Milan and my institution.
Okay, thank you very much. My question now about, first of all, patient selection again, but not by BRCA mutation. You mentioned in conclusion, very general and very good statement that immunotherapy is one of the standard of care in the triple negative neoadjuvant, but not for small tumor.
No.
But within that tumor, do you prefer to keep it for premenopausal, not positive, family history? I'm telling you that why, because in our institute, we cover the patient 100% from the government, and we have to select because of budget, we cannot offer immunotherapy to all triple negative. So any criteria that help me for patient selection may increase my quality of service.
Yes.
So can you highlight some what has happened in your
My institution.
it's one size fit all, or you select?
No. Okay. Thank you for your very brilliant question. Your question is the everyday conundrum in our clinical practice. If we take the international guidelines, we saw there is a discrepancies by the ASCO indication between ESMO indication, between the internal guidelines. We in the patient with the small triple negative tumors, we don't recommend every time neoadjuvant approach, like St. Gallen consensus. We have a cutoff of 15 millimeters. If the tumor is bigger than 15 millimeters, the first choice is neoadjuvant chemotherapy without immunotherapy, because immunotherapy for now is approved in Italy also, only for stage 2 or stage 3 triple negative patient, not for stage 1 for now. For the patient with a tumor smaller than 15 millimeter, we recommend instead the surgery and then personalized chemotherapy that could be shorter than anthracycline, because maybe we can recommend also docetaxel cyclophosphamide for 4 or 6 cycles, sparing anthracycline administration.
Did you do any tumor infiltrating lymphocyte to predict the effect for the immunotherapy? Because we know that PD-L1 and PDL is not a prognostic or predictive marker for in the breast. But we know that tumor infiltrating lymphocyte, highest percentage in the tumor, may give us a good prognosis.
TILs are the topic of my postgraduate, and I fight every day with my director about TILs, because I am very favor about TILs, about the value of prognostic and predictive. I have made some study about predicted value of the TILs in HER2 positive and triple negative breast cancer. But my director, in the opinion of my director, of my chief, for now, TILs are not enough data to guide the treatment, but is not my opinion.
You know, in triple negative disease, I usually advise all the pathologists all over Egypt to do 2 things: tumor infiltrating lymphocyte and androgen receptor. It's cheap, it's easy, can be done without any delay. And according to these 2 parameters, we can predict or do precision medicine.
Yes, totally agree.
Okay.
Okay, thank you so much, Professor Giuseppe, for your presence in Egypt. Thank you so much. And now we move to the next speaker. Let me present to you our eminent speaker and our dear colleague and friend, Professor Ola Khorshid. Professor of Medical Oncology and Head of Medical Oncology Department, NCI Cairo. She's gonna tell us a brief about the updates in the management of advanced triple-negative breast cancer. Professor Ola, the floor is all yours.
Thank you, Dr. Rami, but let me just start by, first of all, congratulating my dear friend, Dr. Amani Hilal, and طبعا Professor Hebel Zawahri. Bahia has been there for 7 years, and it's becoming an iconic place for treating breast cancer patients. It is an iconic place for treating breast cancer patients. So this is only done not by the place, it's by the people, and great clap to you. So triple negative breast cancer patients, it is one of the advanced disease. It is one of the worst diseases in oncology. The problem with triple negative breast cancer is that the survival is quite poor. It's the worst in all subtypes of breast cancer. And we don't have a lot of drugs, or we didn't have a lot of drugs to treat those patients. So this is historically, this is how we used to define triple negative breast cancer as hormone receptor negative, ER less than 1%, PR less than 1%, and HER2 negative, whether by immunohistochemistry or 2+, but FISH negative. And we know that triple negative breast cancer accounts for around 20% of all subtypes. Oops. So but however, this has changed because we found that patients who have a low hormone receptor expression, meaning 1 to 9% hormone receptor expression, those patients actually act like they are hormone receptor negative. So you can see, and this is data from the locally advanced disease. You can see that the response rates, pathological CRs, the recurrence rate, the relapse rate, and the metastasis, the probability of metastasis looks much more like the hormone triple negative versus the hormone receptor positive. This is why the ABC5 has clearly said that patients with low hormone receptor positive, HER2 negative advanced breast cancer should be considered as triple negative breast cancer. And you should not consider giving endocrinal treatment exclusively to those patients. And this is a new statement. So facts about triple negative breast cancer patients, that their overall survival is quite poor. If you look at the hormone receptor positive and the HER2 positive, the median overall survival for patients who have metastatic disease is 40 months. It's around 40 to 44 months. HER2 positive, hormone receptor positive. When you look at the triple negative surrounded in orange there, it is only 14-month median overall survival. So you can imagine how poor the survival is. And we have not been able for the longest time to improve the survival of those patients. We don't have a lot of options. And despite the fact that this is a very sensitive disease, by the way. So patients are going to respond. However, they are going to relapse very high. And when they relapse, the problem, and this is the real problem that we have in triple negative breast cancer, is that for second-line treatment, the responses are quite dismal. You're talking about less than 10% response rate with whatever second-line treatment that you give. So this is the problem with triple negative breast cancer. We know that it's a disease of the young age. Typically, your patient is going to be less than 50. We know that 85% of the BRCA carriers are going to be triple negative. And in your triple negative breast cancer patients, 20% are BRCA mutated. They are going to present mostly with high grade, and they have a very high relapse pattern. And the problem is that 45 to 50% of those patients are going to be having cranial metastasis, brain metastasis, or visceral in the form of lung or liver. So this is, again, the biggest challenge that we have with the triple negative disease. So historically, this is all that we had, is that to give sequential single agent chemotherapies, whether taxanes, anthracyclines, if not used before, antimetabolites, and so on. And the problem is that the only response rate that we could get was 30%, with a median progression-free survival of 6 months and an overall survival of a maximum of 11 months. And trying to improve on these results was to try to combine nocitaxel with capecitabine. There was an improvement in response rate and time to treatment progression, overall survival, but as you can see, the maximum was around 14.5 months. And then trying to find a better drug, what other better drugs that we have, and the study, the 301, was actually an old trial. However, it did show that eribulin was a better drug than capecitabine in terms of overall survival, especially for patients with triple negative disease. You can see that the median overall survival in the triple negative disease was 14.4 months compared to 9.4 months. Then we understood we wanted so much to find a marker to be able to give better treatments. So we know that BRCA mutation it's mutant in around 20% of triple negative breast cancer patients. And for those patients, platinum is ideal. And this is based on a lot of trials, but this trial in particular clearly showed that if you give your BRCA positive or BRCA mutated patients platinums, you can see that the response rate rises from 30% to around 70%, which made the ABC clearly demonstrate that carboplatin is an effective and more favorable drug to be used in the triple negative breast cancer. What about giving bevacizumab? So bevacizumab was tried in a lot of trials, and it did show some progression-free survival improvement. However, there was no improvement in overall survival. And there are some countries that still approve Bev in combination with chemotherapy. However, it is not approved everywhere. Then we went again through the era of understanding more the pathology of triple negative breast cancer, better molecular characterization, and understanding that there is an increase in the immune infiltrates. So just as you heard now, the triple negative breast cancer, they have more tumor infiltrating lymphocytes. The immune system is quite active in it. BRCA is important, and the androgen receptor, as you heard from Professor Heba right now. So this led to us trying to use better drugs and try to personalize our treatments. So this is where we started to use the PARP inhibitors. And we have two very important trials, the Olympia trial and the BRCA trial. These are phase 3 trials that clearly showed in the triple negative breast cancer patients compared to chemotherapy in patients who have received prior lines of treatment, there was a significant improvement in the overall response rate, so that you can get an overall response rate of 60% by a PARP inhibitor, and a progression-free survival in the ranges of 7 to 9 months according to the drug. So on the right here is the olaparib data, 7 months compared to 4.2 with a hazard ratio of 0.5, and the talazumab data, which is, as you can see, median progression-free survival of 9 months compared to 5.6 months, and a great hazard ratio. Now, if you're going to be using PARP inhibitors, it's better to use it frontline. Early on, before chemotherapy. So if you look at the overall survival on the left here, you can see that giving the PARP inhibitor before the chemotherapy, you can actually have an overall survival of 23 months compared to 15 months with chemotherapy with a hazard ratio of 0.5. You don't see that if you're going to give PARP inhibitor post-chemotherapy. And this is just to tell you the data again, just to summarize the data. Responses are 60%, progression-free survival in the ranges of 9 months, and overall survival in the ranges of 23 months with the PARP inhibitor. So definitely, this is an improvement on what we had for chemotherapy. Then came the question, how about adding PARP inhibitors to chemotherapy? And we had the Brocade trial. This was a randomized trial that includes 513 patients. It was a 2-to-1 randomization, where they randomized patients with germline BRCA mutation, HER2 negative disease, to veliparib, carboplatin, paclitaxel, or chemotherapy alone. And you can see that initially there was no difference in the progression-free survival. And then later on, there was a separation of the curves with a progression-free survival of 14.5 months compared to 12.6 months with the combination. So that is, again, an interesting thing that we need to explore more if we are going to be using the changing the guidelines. Now, why are we talking about immunotherapy in triple negative breast cancer patients? For 3 important reasons. First of all, it's highly mutagenic. There's a very high mutation rate in triple negative breast cancer. There is an increase in T-cell infiltrations and PD-L1 expression. So this led to trying immune checkpoint inhibitors as single agents in second and third line triple negative breast cancers. This is the Keynote 119 trial. In this trial, this was actually a negative trial. When compared to chemotherapy, you can see that there was no real difference in the progression-free survival. However, for those patients who had high PD-L1 expression, the CPS more than 20, there was some separation of the curves and there was an improvement in the progression-free, in the overall survival. So yet, again, we never use immune checkpoint inhibitor in the second or third line as a single agent. So what about combining it with chemotherapy? And the idea is that when you add chemotherapy to the immune checkpoint inhibitors, you are enhancing the efficacy of the immunotherapy, you're increasing the antigen release, you're upregulating the PD-L1 expression and improving the efficacy of the immune therapy. So we had three phase 3 trials which randomized patients to chemotherapy compared to chemotherapy with the immune checkpoint inhibitors. The Impassion 130 was atezolizumab with nab-paclitaxel compared to nab-paclitaxel, and then there was the Impassion 131, atezo with paclitaxel compared to paclitaxel, and the Keynote 355 trial, which is chemotherapy, pembrolizumab with chemotherapy compared to chemotherapy alone. And you can see, and the numbers of the patients in these trials were actually quite good. So we're talking about in the 900s and 800s. These are all phase 3 trials. And this is just to randomize the chemotherapy backbone of each of these trials. And this was first line in triple negative breast cancer patients. Now, atezolizumab, when it was added to paclitaxel in the Impassion 131 trial, this was actually a negative trial. There was absolutely no benefit from adding atezo to paclitaxel, and you can see that the progression-free survival and overall survival, absolutely no difference. And then came the Impassion 130, and the reason they did the Impassion 130 with nab-paclitaxel because they feared that the steroids that we were using with the taxanes would affect the efficacy of the immune checkpoint inhibitor. And in this trial, the progression-free survival was improved. The primary endpoint was progression-free survival in the intent to treat population. And however, there was no difference in progression-free and overall survival in the intent to treat population. Despite it was numerically better, however, it was not statistically significant. So based on this data, the Roche had to withdraw atezolizumab indication for the PD-L1 positive metastatic triple negative breast cancer in the United States. Now, Keynote was different. Keynote 355 trial, it randomized patients to chemotherapy, whichever the investigator would use, with or without pembrolizumab. And progression-free survival was significantly improved within the Keynote 355. You can see there was doubling of the progression-free survival, especially if the patient had high PD-L1 expression with a CPS more than 10. And overall survival, this was actually published very recently, last year by Dr. Hugo in 2021, the ESMO before the last one. And you can see that the overall survival was significantly higher. It was, you're talking about 23 months compared to 16 months. So adding immune checkpoint inhibitor to pembrolizumab to chemotherapy in the triple negative breast cancer, you're able to improve the progression-free survival and the overall survival of the patients. Overall survival, we're talking about 23 months compared to 16 months. So that was the reason it became FDA approved for the frontline treatment of the, especially in your PD-L1 high patients, CPS more than 10. This is the cutoff level, the CPS more than 10. And that the improvement in survival was seen in all patients, but specifically it was in the PD-L1 positive disease. So just wanted to put a summary of all the trials for immune checkpoint inhibitors in the triple negative breast cancer for the frontline treatment. Impassion 130 was a negative trial. 131 was a negative trial. The only trial that was positive was the Keynote 355. So if you're planning to use immune checkpoint inhibitor, then pembro with chemotherapy. Now, if it's important to know what kind of and how are we going to measure our PD-L1, and In the past, we had to do for Atizo, the SP142, and for the Pembro, the 22C3. Now it is mandate. We don't, since we're not using Atizo, then the only assessment that we do is the 22C3 CPS1. This is the marker that we use for pembrolizumab. Now, the other question is, should we assess the PD-L1 expression on the primary tumor or on the metastatic? It will be higher expressed in the primary tumor, and actually it can be lower expressed in other sites of the, in different sites of metastasis. So for example, liver metastasis, the expression of PD-L1 is much lower than if you take a biopsy from the lung, for example, or from the skin or so on. Yet, if you are going to be giving an immune checkpoint inhibitor, it makes more sense to go for to take a biopsy from the metastatic site. And it seems that progression-free and overall survival does really correlate with the PD-L1 expression there. Now, so we have two important drugs that we are now using in triple negative breast cancer. We have the immune checkpoint inhibitors and we have the PARP inhibitors. Can we combine both? And this is based on the idea that when you combine the PARP inhibitor and the immune checkpoint inhibitors, you're actually increasing the cytokine release, activating the STING, and increasing the effector T cells. However, this it was a wonderful idea. However, the preclinical trials and the preliminary trials did not show really a difference in overall response rate between the PARP inhibitor and adding the immune checkpoint to the PARP inhibitor. So I don't think that this is going to be continuing. Now, ACT pathway is highly activated in the triple negative breast cancer patients, either due to loss of the function of negative regulators, such as the PTEM, or gain of the function of the positive regulators, such as the PI3 kinase. It is active in 35% of triple negative breast cancer patients. And the Opportunity trial, 130 trial, looked at adding ACT inhibitor to chemotherapy to paclitaxel. However, this trial was a negative trial, no difference in progression-free survival. Now, the other thing that really changed the way we treat triple negative breast cancer patients is identifying the TROP2. So TROP2 is a transmembrane receptor that is encoded in the intracellular calcium signal transduction gene. It signals for self-renewal, for proliferation, for invasion, for survival. It's the green one. So it is upregulated in as high as 85% of triple negative breast cancer patients. And when it's upregulated, it is associated with very poor prognosis. So sacituzumab govitecan is actually a monoclonal antibody drug conjugate that is targeting the TROP2, specifically targeting the TROP2 receptor. So the ASCEND trial is a phase 3 trial that is a confirmatory trial for the efficacy of sacituzumab govitecan in the relapsed refractory triple negative breast cancer patients. This is a phase 3 trial that included more than 500 patients who have received multiple lines of treatment. 25% of those patients actually did get immunotherapy before. So those were patients who were very well treated with the best lines of treatment for triple negative breast cancer patients, and they relapsed. So very difficult to treat patients. And that was, they received the antibody drug conjugate, sacituzumab govitecan was given day 1 and day 8 every 21 days intravenously compared to the physician's choice of chemotherapy. And this trial, actually, they stopped it early because of the compelling evidence for the efficacy of this drug in this population of patients. The overall response was 35% compared to only 5% when you give chemotherapy. And more importantly was the progression-free survival, significant improvement, 5.6 compared to 1.7 with a hazard ratio of 0.4. And the overall survival was significantly higher, doubling of the overall survival, 12 months compared to 6 months in a difficult to treat group triple negative breast cancer patient after they have received multiple lines of treatment. So this has become the standard treatment in third line for triple negative breast cancer patients. So Apparently, there is some change. This is definitely better news for triple negative breast cancer patients. It is not that negative as we think. There are now markers that we can target. So for patients who are BRCA mutant, PARP inhibitors did improve the response rate 60%, progression-free survival 7 months, overall survival 23 months. If you have a patient who has a high PD-L1 expression, then the indication is to give immune checkpoint inhibitor with chemotherapy with an overall response rate of 60%. Again, progression-free survival is 10 to 5 months, overall survival of 23 months compared to 16 months with chemotherapy. And for the third line treatment, then sacituzumab govitecan is now indicated for where you are still going to get overall response of 35% and progression-free survival of 10 months and another 12 months. So it seems that we are truly improving the results of our triple negative breast cancer patients. And this is actually a slide that I modified from Rebecca Lang. And so basically you have to check for your PD-L1 and BRCA positive. If you have a PD-L1 and BRCA positive patient, then the best thing to do is to try to give the patient immune checkpoint inhibitor, because we know immune checkpoint inhibitor with chemotherapy is best given as frontline. If you cannot do this, then you can give chemotherapy, including platinums or a PARP inhibitor. For second line, for those patients, then it's a PARP inhibitor with chemotherapy. And if it's BRCA negative, then standard of care chemotherapy. If the patient is PD-L1 negative, then for those patients and she's BRCA positive, then PARP inhibitor or platinum chemotherapy or standard chemotherapy. And for third line treatment, it is sacituzumab govitecan. This is now the standard of care. And what I did in this slide that they have removed is that I have removed the line of nab-paclitaxel with atezolizumab. It is no longer indicated for patients with triple negative breast cancer patients. And this is the ESMO guidelines, as I have just said. It's really, we're treating patients again based on your PD-L1 BRCA mutation and where you can truly tailor your treatment for those patients. And thank you. And last thing I would like to say that I would be honored to invite everyone to the National Cancer Institute Congress, which is going to be on the 2nd to the 4th of November. Thank you very much.
Thank you, Professor Aula Khorshid, for this interesting and informative lecture as usual. Let's move to the next speaker, and we will postpone the question to the end of the session. Next speaker, Professor Abir Shaban, Professor of Breast Pathology at Queen Elizabeth Hospital, Birmingham, UK. She will talk about the recent advances in HER2 and PD-L1 testing in breast cancer. Please, Dr. Abir.
Thank you, Dr. Manal, and it's a pleasure to be with you today. I think I contributed before virtually, and this is my first time to join you in person. Thanks to Dr. Gada particularly for inviting me. And I think this lecture will follow nicely from the previous talks about the molecular testing in breast cancer, particularly focusing on HER2 and PD-L1 testing. So let's start with HER2 testing. And what is a good test, a best test? There are lots of tests available to assess the HER2 content in tumors, including protein, DNA, and RNA assay. But a best test has to be reproducible to accurately determine the level of HER2 expression and to correlate with the outcome. Some places recommend FISH testing, but the standard is that we start with protein assessment using immunohistochemistry and validate by FISH testing in the borderline ones. And that's what we do in the UK, and we focus on standardization and the quality control of immunohistochemistry and ISH testing. We're all aware of the quantitative assessment and a morphological correlation. It's a cheap, fast, and quick method of assessing HER2 expression, and we're looking for strong membrane positivity, and the cutoff value currently is 10% to call it 3+. Our real-world data from the NICOAS assessment scheme shows that about 13% overall are HER2 positive. And the rate does not differ if you assess on core biopsy or excision. So it's perfectly safe to assess ER, PR, and HER2 on core biopsy. It is lower in bone metastasis due to the effect of decalcification. And in about less than 20%, fish will identify HER2 amplification. It's really important that as we pathologists get the results right, and you will be aware of different QA assessment schemes. One of them is the UK National External Quality Assurance Scheme, where all of us as breast pathologists and labs have to participate in. They send us slides from their end, and we also assess our own in-house slides. And if you provide too inappropriate tests or results, you are in big trouble. So we always have to be on top of it. Pathologists and labs have to test adequate number of cases to maintain proficiency and expertise, and to include validated controls. The question is whether we should test on core biopsy or excision, and all these studies, including our own, showed that we can rely on the results of testing on core biopsy, but there are some indications for repeat, and there are some possible discordant cases. First of all, if there is inadequate fixation, you might get discordant results. Usually core biopsies are small and better fixed, so the results are more accurate. If the patient had treatment, neoadjuvant chemo or neoadjuvant endocrine therapy, you can have heterogeneity of tumor or inter-observer variation, or if you have a very tiny amount of tumors that you cannot assess on. So these are all indications to repeat testing if you've already done it on core biopsy. This is an example of heterogeneity where most of the tumor, for example, is negative, and then you have a positive clone. This is a different type where you have a mixed positive and negative cells. You can also get heterogeneity by testing by in situ hybridization. So you can have an area of the tumor where there is amplification and another area where there is no HER2 amplification. And this heterogeneity has been shown, as in this study, to affect the PCR rate. So the PCR rate in the heterogeneous group is less than straightforward positive ones. This takes us to the indication of repeat. When should pathologists repeat testing on excision if they have already done it on core? Technical issues. If you're not happy about the quality of staining or adequacy of the sample on core biopsy, you should repeat it on excision. If there is recurrent or metastatic disease, as we've just heard, it's important to biopsy the metastatic disease and repeat the receptors because they can change between the two biopsies. If you identified multiple clones or different grade of tumors, say your core biopsy was a grade 1 and then your excision is a grade 3 tumor, that's an indication to repeat. Borderline fish results, usually around the ratio of 2. This can go either way. So it is desirable to repeat. And we also repeat following treatment, either neoadjuvant chemotherapy or neoadjuvant endocrine therapy, and where there is residual disease, because this is resistant disease. I just have to say this is not mandated in the UK guidelines now, but many of the UK laboratories would repeat testing following therapy. This is to show you the receptor change after neoadjuvant therapy for breast cancer. This is a review if you would like to read a lot in detail and see the evidence. Changes in the ER status is reported in up to 23% of cases. PR is actually more likely to change between after chemotherapy or endocrine therapy, up to 2/3 of the cases. HER2 changes are less common, but they are usually from positive to negative, particularly after the use of anti-HER2 therapy. And fish testing is more stable. So sometimes you find some changes in the protein expression, but when you test by fish, there is no change. Of all the molecular subtypes, the triple negative breast cancer is the most stable. So this is the least likely to change after treatment, while the ER positive and HER2 positive tumors are more likely to show a change. And these are some of our own cases after neoadjuvant chemotherapy, a change from positive HER2 to negative, and the other way around as well. After neoadjuvant endocrine therapy, again, you can get the same, and this is one of our cases. The case was completely negative for HER2 before neoadjuvant endocrine treatment and became 2+ after therapy, but it was still FISH negative. When we have metastatic disease, there is a lot of evidence now to suggest that we need to biopsy the metastatic disease, first and foremost to confirm the diagnosis, that this is definitely metastasis, and this is metastasis from breast cancer, not from something else. And to repeat testing ER, PR, HER2, and now PD-L1 as well. And several studies have shown that there is a change in the status and a change in the management based on the new biopsy. Receptor conversion can occur in distant disease compared with the primary, and this showed that for PR, for example, 30% of cases have changed. An important point for pathologists when we test in bone metastasis, and it's not uncommon to get a biopsy of bone metastasis, it can work really well, but it is important to make sure that we do not use strong acid decalcifiers to assess for this. So EDTA, EDTA, is more recommended if you want to test for receptors. Fast turnaround time is really important. It's quite variable actually in the UK, depending on what model you use, but ideally ER and HER2 should be available for the first diagnostic MDT and also for the metastatic MDT. And we did a piece of work on the referrer from decision to refer to availability of results. And we found that there are some blocks along the pathway, and these were causes of the delay, batching of the request, transform of blocks between labs, availability of staff. And for FISH, if FISH is needed, this includes an additional 1 to 2 weeks till the results are available. And that's why some places prefer to use chromogenic in situ hybridization like DDISH for testing. If you want to look at pathways and how to achieve fast HER2 testing, this is one of our papers on behalf of the NCRI translational subgroup. As you know, we have the current categories of score 0, 1+, considered negative, and then 2+ assessed by FISH, and then 3+ straightforward positive. These guidelines have changed over the years, with cutoff changing from 30% to 10%. And there is some discrepancy between the guidelines, the ASCO guidelines, particularly in this category, where you have a score ratio of more than 2, but average HER2 less than 4. In the UK, we still follow the ASCO guidelines in 2013, and we would regard this as positive, while the ASCO guidelines would regard as negative. So our guidelines are being updated now, so look out for the new UK guidelines already submitted, and we have no change in the cutoff, or we're not following the ASCO in this particular area of more than 2 ratio. And this is a glance at how the UK will be scoring the guidelines, because if you follow the guidelines, you will see that there are entities that are missing. So we will look at the percentage, expression, and intensity, and this will be our new guidelines in the UK. Just to touch on a new entity called HER2 low breast cancer. Traditionally, we never bothered to distinguish between score 0 and 1+, because we call them both negative. However, new therapies are being developed for particularly hormone receptor positive HER2 low breast cancer. And the definition of HER2 low is the HER2 1+ or the HER2 2+ FISH negative. So this is the new category of the HER2 low, and it's not a trivial category. It's about 50% of all breast cancer, and they include the luminal and the triple negative breast cancer, Currently, we regard them as HER2 negative, but there are some new drugs that are targeting this group. And this is called, the drug is called Enhertu, and is the first anti-HER2 drug to show efficacy and safety in the HER2 low advanced breast cancer. So we will be looking at this in more detail. There are HER2 trials, lots of them at the moment. The latest is the DAISY trial, and this has been presented. Actually, this is from ESMO, latest ESMO, and that showed significant response to in the HER2, even 0 tumors. So we are going to treat even the very low, what we call ultra low HER2. This takes us pathologists to an important point of concordance of assessment and really being able to identify that. And also remember that a tumor can move from HER2 0 to HER2 low in the metastatic setting, or from 3+ to HER2 low in metastasis. So that's another reason to repeat testing. If you go to the PD-L1, and I'm not going to talk through the trials because they have already been covered really beautifully before, just testing on the assays. So the Ventana SP142 assay for atezolizumab treatment looks only at the stroma. So we don't bother about the tumor expression at all. We only look at the stroma, the immune microenvironment, and the cutoff value for positivity is 1%. We have also another drug, which is pembrolizumab, which shows the combined positive score, and this cutoff value of positivity is more than 10. So in this one, we would look at the stroma and the tumor as well. And we calculate the combined positive score of both. And if it's more than 10, that is positive. Actually, a difference in the UK is that we still use SP142 and atezolizumab for the metastatic triple negative advanced breast cancer. So our oncologists in the UK would have both drugs, atezolizumab and pembrolizumab, and therefore we test both. So we use the SP142, the Ventana assay, and the DACO22C3. We test both, and sometimes it's one positive and one negative, so the patient would have both, can have either drug. By tissue, as was touched nicely on before, it differs between primary and metastatic setting. So it is more expressed in the primary setting, but in the metastasis, there are particular areas that express more, like in the lymph nodes, for example, and while bone and liver express very little PD-L1. And sometimes actually when our oncologists are desperate to find a positive result, we would test more than one sample. So we can test the breast, then followed by the lymph node and so on. But you can test on any sample. We try to avoid liver and bone, and avoid, if you have to use bone, so EDTA decalcification is preferred. You can test PD-L1 on core or excision, on the primary, nodal mets, distant metastasis. You can do it pre or post NACT and check controls before testing. So the scoring, you have guidelines as to how to score it. If you're using the Ventana PD-L1 SP142, then it is a percentage score only in the tumor microenvironment using a 1% cutoff value for positivity. And this is an example of one of our cases where this is just over 1%. We always have a section of the H&E as well. We need really to correlate the tumor with the morphology with the assessment. And this is a beautiful example. If all cases were like that, that life would be easy, but it's not. This is a straightforward positive. And this is the 22C3, where you would assess both the tumor and the microenvironment and come up with the score divided by the total number of viable tumor cells. When we test, we use controls. So you use cell lines that have various degrees of expression, strong, intermediate, and negative. And we also have a tonsil tissue control. So this is our standard control, cell lines and tonsil. You have resources there available to assess both tests. So look them up, and what we do as well is to contribute to the National External Quality Assurance Scheme if you're reporting PDL1, and there are online training and proficiency tests available for those who are starting to assess for PDL1. Even from outside the UK, you can join the UK National External Quality Assurance Scheme. It's not a free test joining, unfortunately. You have to pay, but you can join and you can get a certificate for proficiency to show that you are assessing it well. Currently, NIQAS are assessing SP142, but they are introducing the 22C3 assay soon. And this is a final review. If you want to read a bit more about an update of what we do in breast cancer in general, including HER2, PDL1, BRCA, and others. Thank you for your attention.
Thank you for the nice presentation. And now I have the honor to introduce my dear colleague, Assistant Professor Dr. Muhammad Guma. And he is, I'm proud to, he's one of my students. And his talk will be about imaging of triple negative breast cancer and benign cancer mimics.
Sign. Imaging of triple negative breast cancer and benign cancer mimic. The previously disused classification method of breast tumor have been used to determine the nature of the breast lesion. They don't provide sufficient information for accurate therapy, and they are inadequate in assessment of tumor prognosis. For this reason, several distinct molecular subtypes of breast cancer have been defined. Is it important to know the receptor status? By identifying the receptor status of the breast cancer cells, your doctor can recommend the effective treatment to stop the tumor growth. And the breast cancer cells either showing estrogen receptors that bind with estrogen hormone, or progesterone receptors that bind with progesterone hormone, or showing human epidermal growth factor receptors, or either breast cancer can showing no estrogen or progesterone or HER2 receptors and considered as a triple negative breast cancer. To stop the tumor growth for hormonal receptor positive is indicated for hormonal treatment. And if the breast cancer show HER2 overexpression, it is indicated for trastuzumab. And if the triple negative, to stop the tumor growth. Molecular subtype of breast cancer, according to Stephen Gallen, international expert, determined biological classification system based on expression of the tumor marker, either estrogen receptors or progesterone receptors, or human epidermal growth factor, or proliferative index Ki67. The breast cancer molecular subtype divided into luminal A breast cancer or luminal B breast cancer, or HER2 overexpression or triple negative breast cancer. Distinct difference in tumor genetic result in different pattern of disease expression and different response to therapy and different patient survival outcome. And also the prediction of molecular subtype of the breast cancer is important for diagnosis and also prognosis, and also to predict the response to treatment. Molecular subtype of breast cancer, either luminal A or B or HER2 overexpression according to the hormonal status. As we see here, luminal A is strongly positive ER and strongly positive BR, and HER2 negative with low Ki67.
Those patients showing best prognosis with high survival rate and low rate of recurrence. Luminal B breast cancer showing ER positive and BR positive and HER2 either negative or positive with high KI, and showing poorer prognosis rather than the luminal A and usually affect younger age with high grade. HER2 positive breast cancer also showing ER negative and BR negative and HER2 strongly positive with high KI, and most of these patients showing poor prognosis and affecting younger age in comparison to other group. Triple negative breast cancer showing negative ER receptors and PR receptors and human epidermal growth factor with high KI, and this patient are showing worst prognosis and usually affecting young patient with BRCA mutation with high incidence of recurrence. Do the molecular subtype of breast cancer have specific imaging feature? Triple negative breast cancer more frequently presented in mammography as rounded or oval or lobulated masses, and less frequently associated with calcification or DCIS. Also showing the worst prognosis compared to other breast cancer and showing more aggressive behavior. And also has high rate of recurrence in comparison to other subtype, and other subtype usually presented as a speculated irregular mass or non-mass enhancement. Do the molecular subtype of breast cancer have a specific imaging feature? Triple negative breast cancer usually showing rapidly growing breast cancer with high rate of recurrence and usually affecting the young patient with BRCA plus or minus BRCA mutation. Ultrasound usually shows circumscribed mass with posterior enhancement and the central cystic area. But MRI usually showing a bright T2 signal with ring enhancement. And some of these patients showing lung and brain deposit. Case number 1, 38-year-old female patient presented with right breast mass, as we see here. In mammography, right breast upper outer quadrant will define the isodense mass, and the corresponding ultrasound showing circumscribed mass with posterior enhancement and the central cystic area. Right breast ultrasound guided core biopsy consistent with metaplastic carcinoma, carcinosarcoma grade 3 triple negative breast cancer. Case number 2, 49-year-old female patient presented initially with right breast mass at February 2020. In mammography showing right breast upper outer quadrant dense mass with lobulated posterior outline, and the ultrasound showing lobulated hypoechoic lesion showing heterogeneous echo pattern and posterior shadowing. Baseline CT at 2020 show no definite pulmonary or hepatic or osseous metastatic deposit. Corneal biopsy showing triple negative breast cancer, invasive duct carcinoma grade 2. Follow-up at 2021 and 2022 by mammography showing clear operative bed with no evidence of residue or recurrent disease. But CT that was done at 2022 showing newly developed pulmonary and osseous metastatic deposit and matching with the behavior. Case number 3, 40-year-old female patient presented with right breast mass, as we see here in the mammography showing a right breast upper inner quadrant well-defined dense lesion with radiolucent halo, seen in the Milky Way and also associated with bilateral small nodules. Contrast-enhanced spectral mammography showing a right breast intensely enhancing upper inner quadrant well-defined lesion, with bilateral intensity enhancing nodule being more worrisome owing to their well-defined appearance of the dominant primary mass. Positron emission mammography was ordered to confirm their nature. Positron emission mammography showing right breast upper inner quadrant single FDG avid lesion and showing no FDG activity, overlying the previously described bilateral multiple enhancing foci that described in the contrast enhanced mammography. And this patient underwent wide local excision and sentinel lymph node biopsy and revealed invasive ductal carcinoma grade 3, and the resection margin are free of the tumor, and the left breast excisional biopsy from adenotic nodules reveal fibroadenosis and adenotic nodules. Case number 4, 4-year-old female patient presented with right breast mass triple negative invasive ductal carcinoma grade 3. Dynamic MRI showing right breast upper outer quadrant enhancing lesion showing ring enhancement. And showing also in T2 and the stair weighted image showing bright T2 and the stair signal. Also in diffusion weighted image revealed diffusion restriction and dynamic curve listed as a washout curve. Case number 5, 53-year-old female patient pathologically proved triple negative invasive ductal carcinoma. As we see here, left breast intensely enhancing mass associated with enlarged pathological axillary lymph node. Also, this patient showing type 3 washout curve, and the pathology revealed the triple negative invasive ductal carcinoma. Follow-up dynamic contrast enhanced MRI after neoadjuvant for this patient showing near complete response of the previously described left breast enhancing mass with residual linear fibrotic band, and also changing of the dynamic curve from the washout curve to continuous rising curve. And this is the maximum intensity projection image before the chemotherapy, and this is the maximum intensity projection image after the chemotherapy, denoting complete response. Case number 6, triple negative breast cancer under neoadjuvant chemotherapy, showing in mammography right breast upper outer quadrant, well-defined dense lesion associated with shaggy anterior outline, and also contrast-enhanced mammography showing intense enhancement predominantly at the margin, and the ultrasound showing ill-defined lesion, hypoechoic lesion with posterior enhancement. Also follow-up after neoadjuvant chemotherapy showing in mammography reduction in size and density, and also in contrast-enhanced spectral mammography showing reduction in intensity of enhancement and reduction of the size, and this is confirmed by pathology as a partial response. Case number 7, triple negative breast cancer under neoadjuvant chemotherapy underwent follow-up by positron emission mammography. At the baseline, positron emission mammography showing right breast single upper outer quadrant FDG avid lesion. And post-neoadjuvant chemotherapy by positron emission mammography showing near complete vanishing of the previously noted right breast upper outer quadrant FDG avid lesion with no detected activity, denoting complete response that was confirmed by post-operative pathology. Case number 8, 29-year-old female patient complaining of mastalgia and lumpy breast. In November 2019, this patient coming to us and presented with left breast well-defined hypoechoic lesion and considered as a multiple small adenomas, and the largest one showing loculated outline and linear septa. The patient coming on follow-up on September 2020, most of these adenoma are stationary in course, except the largest one showing more increase in size, associated with newly developed hypoechoic irregular lesion at the same breast and considered suspicious, and this patient was candidate for MRI. This patient doing MRI showing left breast multicentric enhancing lesion and showing washout curve. The biopsy and diagnosis was triple negative invasive ductal carcinoma grade 2. Our differential diagnosis for this patient is fibroadenoma or well-defined malignant lesion, if showing atypical feature. Now we're starting by atypical feature as microlobulation outline or abnormal location or focal obscured border or focal angulation. Also cystic degeneration or increase in size in a follow-up or a change in morphology. We started first when to suspect or worrisome from well-defined lesion as fibroadenoma, as we see here, the ultrasound showing the microlobulated appearance. Also, the focal obscured border and focal angulation. Now we're presenting, this is a case of mammography showing right breast lower inner quadrant, well-defined dense lesion with anterior focal angulation, denoting ductal extension, as we see here. And the ultrasound showing well-defined lobulated outline and posterior and on the medial and lateral focal angulation also presented in the ultrasound, denoting ductal extension. The abnormal location. As we see here, there is usually we have in mammography, usually area showing no parenchymal abnormality at a no man lands or a Milky Way. Usually a presence of any abnormality in those locations usually considered suspicious. As we see here, example for this abnormal location, this is a right breast upper inner quadrant, well-defined dense mass seen in the Milky Way, and this patient considered suspicious by location and ultrasound. Also, cystic degeneration, as we see here, ultrasound for this patient showing well-defined lesion with central cystic area and the marginal vascularity, making this case is more suspicious. Increasing in size as previously described, this patient had well circumscribed the lobulated hypoechoic lesion in November 2019. But in follow-up in September 2020, showing more increase in size and the changing of the morphology, making it more suspicious. And when fibroadenoma showing atypical feature at the microlobulated or focal obscured border or cystic central area, or abnormal location or focal angulation, or increase in size or a changing of the morphology, biopsy is indicated whatever the age. Fibroadenoma, if typical fibroadenoma showing the well-defined feature and with no any area of suspicious, it is under follow-up. Usually the management is short-term follow-up after 6 months. And if stationary in size, is still in follow-up after 6 months for 2 years. But if this fibroadenoma increase in size or change in morphology, usually this patient is indicated for biopsy. A typical fibroadenoma either showing abnormal location or microlobulation or focal obscured border or increasing in size usually is indicated for biopsy to usually exclude a well-defined malignant lesion. Knowing the different classification method of breast cancer and the different imaging feature is essential for all breast imaging radiologists to differentiate between benign and malignant lesion and matching the imaging finding with pathology result and understanding the prognosis and understanding what the surgeon needs to plan for surgery and understanding what the oncology needs to plan for clinical management and give the radiologist an integral role in the patient management to be a clinical radiologist. Thank you.
Thank you, Dr. Mohammed, for your excellent demonstrative presentation. The next speaker, Professor Dr. Rasha Wissam. Here talk about role of the radiologist in axillary management, past and future.
I'm so glad to be with you. I will present to you a role of radiologists in axillary lymph node management, past and present. In the past, axillary lymph node dissection it was the only treatment of breast cancer, and it was used for staging of breast cancer. So first the patient is going to have surgery, and after surgery, the patient will be staged. And according to the staging post-operative, the patient will take the neoadjuvant chemotherapy or adjuvant therapy. Yet, improvement of neoadjuvant systemic therapy and imaging-guided lymph node intervention, staging system by axillary lymph node dissection will become a historical event. And introduction of sentinel lymph node biopsy, making the treatment option making the axillary lymph node dissection as a treatment option of breast cancer is not only the option. Sentinel lymph node become another option for management of axilla. Why axillary lymph node status is important? It's most important prognostic factor that predicting the patient recurrence and survival. It's the end part of TNM staging system of the breast cancer patient, and the extent of nodal disease will determine the pre and post-operative management, whether the patient will take neoadjuvant chemotherapy versus the patient will go for upfront surgery. And post the operation, it will determine the need of radiation therapy. يعني هي بتحدد ان احنا لا اما هناخد نيو ادجوانت او ندخل افرانت اللي هي ان احنا ندخل عمليات على طول without ان احنا ناخد نيو ادجوانت chemotherapy. So the lymph node status is very important. As a part of TNM staging, the end part of the TNM staging, the 5-year survival of the patient will decrease as increases the staging of the breast cancer. As you see here, we're going through stage 0 to stage 4 by increasing the lymph node staging. The 5-year survival of the patient will be decreased. There is multiple system for staging of lymph node. There is clinical staging system, imaging staging system, pathological staging system, and biological staging system. As radiologists, our staging system, it is the imaging staging system that is the same as the clinician. The only adding value of the clinician that is not similar to us is the palpation. So fixation of lymph node is a clinical findings, it's not a radiological findings. This is the only difference between clinical staging system of the clinician and the imaging staging system of the radiologist. And as you see here, the staging system of the lymph node increased by increasing the lymph node levels. Once you are going through N1 to N3, the stage of the breast cancer has been increased. We are not talking about lymph node number. As you see, as a radiologist, we count only on the level, not on the number, as pathologists. Here, the pathological staging system, as you see, because the patient already did the operation, so the only one that he can count actually the lymph node is the pathologist. So it's staging system based on the number of lymph node. And keep in mind that increasing the number more than 3 will affect the patient, and you will see later on. As we see here, greater nodal involvement will decrease the patient survival. Once there's no lymph node stage, lymph node positive N0, this is the survival of the patient. And once there is lymph node involvement from 1 to 3, there is the survival of the patient. And once the lymph node involvement become more than 3, and next time we are concentrating about number 3, there is dramatic decrease in the patient survival once the lymph node number has been increased more than 3. So keep in mind, lymph node number 3. What's the importance of lymph node level that the radiologist should mention in his report? It's a part of end staging system of the breast cancer. It gives idea about the burden of nodal disease, and I will discuss this point later on. What is the burden of nodal disease? And when the surgeon perform axillary lymph node dissection, they remove level 1 and 2, but not level 3 supraclavicular or internal mammary lymph nodes.
Otherwise, the patient will take neoadjuvant chemotherapy. That means that when the radiologist mentioned there is involvement of level 3 supraclav or internal memory, he is telling the clinician and the oncologist, you cannot go for upfront surgery. The patient should take neoadjuvant chemotherapy. So when you are mentioning the level of lymph node in your report, you give it an idea about the management of the patient. She will go to neoadjuvant chemotherapy, or the patient will go for upfront surgery. This is the lymph node levels. The lymph node levels is the pectoralis minor. Classify the lymph node level into level 1 and 2 and 3. The lymph node that is lateral to the pectoralis minor is level 1. That's related to pectoralis minor, this is level 2. What is medial to the pectoralis minor, this is level 3. And this is the supraclav, and this is the internal mammary lymph node. As we mentioned before, the surgeon remove axillary level 1 and level 2. So once you are saying there is level 3 supraclav or internal mammary, you are telling the surgeon you cannot go for surgery. So N1, this is mobile ipsilateral level 1 and or level 2. N2, fixed or mated ipsilateral level 1 or 2, or isolated internal mammary. Fixed, it's a clinical staging. It's not a radiologist staging, while matted axillary lymph node, it's your rule while you are doing ultrasound to mention if it's matted together, because this just word will make the patient come upgraded from N1 to N2. N3, level 3, regardless the status of level 1 or 2, or ipsilateral internal mammary plus axillary lymph node and ipsilateral supraclavicular level lymph node. When you are mentioning in your report that there is contralateral axilla or there is cervical lymph node involvement, you are as if you are writing the patient is M1. It's not N anymore. The patient become M. So it is M1 once you are mentioning there is a contralateral pathologically enlarged lymph node or there is pathological enlarged cervical lymph nodes. You are putting, when you are to determine the level of lymph node, you're putting the probe below the clavicle, and this is the pectoralis. I'm sorry. هي الإضاءة فين؟ البوينتر. This is the pectoralis minor muscle. So what's lateral to the pectoralis minor muscle, this is the level 1. What is related to pectoralis minor, whether it is below the pectoralis minor or in between the pectoralis major and pectoralis minor, this is level 2. And what is medial to the pectoralis minor, this is level 3 lymph nodes. What about supraclavicular lymph node? Supraclavicular lymph node is a triangle that is located between the omohyoid muscle superiorly, the clavicle inferiorly, and the internal jugular vein medially. Internal mammary lymph node, metastatic to internal mammary lymph node usually occur after a tumor has been metastasized to the axilla. Isolated metastatic metastasis to internal mammary lymph node occurs in 1 to 5% of the breast cancer, and usually come from the deep or medial lesion, and it may be the site of recurrence. So once you are notice that the cancer in the breast is deep or medial located, you should look for internal mammary, and you should know that the affection of lymph node usually occur in systematic manner. First, the level 1, there is, then level 2, then level 3, then internal mammary, skipping of the affection in such manner occurring in from 1 to 5% of the cases. This is the internal mammary lymph node. You are putting the probe longitudinally and transversely along the sternum, and this is the internal mammary lymph node. You should, before mentioning this, there is internal mammary lymph node, you should apply color Doppler in order not to miss the internal mammary lymph node with the internal mammary vessels. And normally the lymph node can be reached up to 1 centimeter or 1.3, and it's normal. So please, when you are writing your report, there is internal mammary. First of all, you should apply color Doppler in order not to miss with internal mammary vessels, and mention its size and just it. Don't say it's pathological or not, because normally it may be for up to 1 to 1.3 centimeter, and it's normal internal mammary lymph nodes. Also, it may be the site of recurrence. So when you are follow up the patient of cancer patient after treatment, you should look for internal mammary lymph node because it may be the site of recurrence. So we are finishing our lymph node examination, the levels, level 1, 2, 3, supraclav and internal mammary. What about the intramammary lymph node? What is the rule of radiologists regarding the intramammary lymph node? Actually, the intramammary lymph node now considered as a level 1 axilla, but there is debate in management if it affected, shall we do an evacuation of axilla or not? So there is a debate about intramammary lymph node. Whatever the debate is, but the radiologists have a role in the intramammary lymph node. When there is affection of lymph node in the breast, and it's considered as a multicenteric or multifocal cancer, and the surgeon said that he can make a conservation, you should put a clip inside the lymph node before the neoadjuvant chemotherapy, because it may be disappear after the neoadjuvant chemotherapy. And then this is the pre-neoadjuvant, this is post-neoadjuvant, and the patient will do a wire localization for intramammary lymph node if the conservation is feasible. What's normal and abnormal axillary lymph node? This is the normal axillary lymph node. It is a kidney shape like, but it is different from the kidney, that the lymphatic vessels enter through the cortex, not through the hilum as a kidney. But it goes out from the lymph node as a kidney through efferent channel, and it comes through afferent channel through the cortex. So if the lymphatic fluid have malignant cell, they will lodge themselves within the cortex. So you can see changes within the cortex, and when the cortex has been changed, with time it maybe affect the hilum. The hilum will be affected by indentation or obliteration, but the affection first will be within the cortex. This is the normal appearance of axillary lymph node. It is a reniform with thinner cortex. This is the longitudinal, and this is the transverse, and this is by ultrasound. This is the longitudinal and transverse of normal axillary lymph nodes. This is the MD Anderson classified the lymph node into 5 types. This is 5 types of lymph node, and the management will be based upon these types. Type 1 axillary lymph node, you cannot see the cortex, is very, very thin. It's very difficult to see the cortex, and the hilum also is preserved. While in type 2, the cortex, you can see it, but it is not exceeding 3 millimeter. It's below 3 millimeter. Type 3, there is a diffuse affection of the cortex. It becomes diffusely thickened. There is no focality, and it is exceeding 3 millimeter. Type 4, there is affection of the lymph node. There is become lobulated. So any lobulation within the lymph node is thought to be an lodging of a malignant cell within the cortex come from outside. So lobulated lymph node in a cancer patient, it should be suspicious. So it makes them type 4, not type 3. Type 3 is the diffuse. Once there is a focality, even if this focality is just lobulation of the lymph node, it is suspicious in presence of breast cancer. Type 5, there is focality within the cortex that may affect the hilum. It may be obliterating the hilum until it reach level 6, when there is total obliteration of the hilum and the lymph node become as if being a mass. According to such types, biopsy or not to biopsy, it will be guided by your institutional MDT guidelines. But according to MD Anderson, type 3 lymph node, type 1 and type 2, which is a very thin cortex, 100% negative predictive value. It is non-specific. Type 3, when there's diffuse cortical thickening, the negative predictive value is 93%. So it may be reactive and maybe cancer, but likely reactive. So in MD Anderson, diffuse cortical thickening biopsy or not, because the patient will go for sentinel. So your guidelines and your institution, your guide your management of lymph nodes. Once we are entering into level 4, 5, or 6, the negative predictive value become less. 89% in type 4, type 5, and type 6, there is high positive predictive value, and the highest at level 6. So this type may be malignant, but mostly reactive. But level 4, 5, and 6, there is a focality within the cortex, so it is suspicious and should be biopsy. So our radiologist report should include such items. And lastly, number of suspicious lymph node, although it's not our staging system. Until now, the number of axillary lymph node is not included in clinical or imaging staging system yet. I will show you how does the number of lymph node making the radiologist and the management of axilla going step to the future, okay? The number of lymph node affection give an idea about the burden of nodal disease. Extensive nodal disease, there's an affection of more or equal to 3 suspicious lymph node, or if there is affection of level 3 supraclavicular or internal mammary. While limited nodal disease, when there is no nodal affection, it is 0, or up to 2 suspicious lymph node in level 1 and 2. Extensive nodal disease, it's managed by neoadjuvant chemotherapy or a front and axillary lymph node dissection. While limited nodal disease, in the future, they will go for sentinel lymph node biopsy, not for dissection. So when you are writing in your report the number of lymph node, you are making your institutional go to further step to the future. In addition to T1 and T2 will determine the management of axilla. What about TAD? This is the future that is going with the number of lymph nodes. TAD is a target axillary dissection. We want just to remove the affected lymph node. We want to decrease axillary lymph node dissection and going toward more sentinel lymph node management. And this will go through TAD. Axillary lymph node dissection has been a standard of treatment of axilla post-neoadjuvant chemotherapy in node-positive patients. However, 40% get the complete pathological response, especially triple negative and HER2 positive. يعني هم لقوا ان العيانين اللي بياخدوا نيوادجuvant chemotherapy وهم عندهم positive axillary lymph node 40% بالذات التريبل نيجاتيف والهير 2 بوزيتيف بيدخلوا في كومبليت باثولوجيكال ريسبونس. طب ليه نشيل بقى الاكسيلاري ليمف نود طالما احنا عندنا كومبليت باثولوجيكال ريسبونس؟ طب ما احنا هنسيبهم ما نعمل اكسيلاري ليمف نود سنتينال ليمف نود بايوبسي ما نعملش ايفاكيويشن. كان في ديبيت على الحالات دي ان احنا تو دو سنتينال ليمف نود بوست نيو ادجوانت كيموثيرابي. ايه المشكله ان احنا نعمل سنتينال ليمف نود post neoadjuvant chemotherapy ان انت after neoadjuvant chemotherapy there is lymphatic pathway alternation. حصل fibrosis في الليمفاتكس فبالتالي في alternation للليمفاتيك pathway فانت مش متاكد ان انت اللي هتشيله من الليمف نودز هم دول الافكتد وممكن تسيب affected lymph node within the axilla. تاني حاجه low identification rate of such lymph nodes and is low and high false negative rate of identification of lymph nodes. So these 2 points making debate in sentinel lymph node biopsy post neoadjuvant chemotherapy. However, a trial was designed at MD Anderson at 2011 to test the hypothesis that the pathological changes in the clipped node actually reflects the response therapy in the other nodes. So TAD come in place. What is TAD? It's a sentinel lymph node biopsy in addition to removal of initially clipped lymph node before neoadjuvant chemotherapy. By making this TAD, there will increase, you will bypass the debate of sentinel lymph node biopsy. There is increase in identification rate, with reduction in false negative rate, and you will make sure that you are selectively remove the biopsy-proven metastatic lymph node, allowing axillary restaging after neoadjuvant chemotherapy. يعني ايه؟ يعني ان احنا عشان نبايباس الديبيت اللي كان بيحصل ان احنا نعمل sentinel lymph node biopsy بوست neoadjuvant chemotherapy، بدأنا نفكر ان احنا هنعمل كليبنج للباثولوجيكال ليمف نود قبل النيو ادجفانت كيموثيرابي، ولازم تبقى فاين نيدل او بايوبسي بروفد ان احنا نتاكد ان هي باثولوجيكالي بروفد ان هي مالجنان. هنحط كليب within these lymph nodes after neoadjuvant chemotherapy we will perform ultrasound if it so after the operation, the surgeon will remove the clipped lymph node in addition to sentinel lymph node. And this is the future of management of the axilla. مش عارفة هينفع.
Thank you, Dr. Arasha, for your excellent and demonstrative presentation. Next, challenge case discussion with Dr. عمرو فاروق, دكتورة أميرة ضياء, دكتورة دينا محمد.
I'm Dr. Amr Farouk, Dr. Dina, and Dr. Amira Diar will be presenting triple-negative breast cancer challenging cases. The first case, a 50-year-old female complaining of an increased sized right breast palpable lump. The sonomammography showed a right breast upper outer quadrant, partially circumscribed, partially obscured dense mass, corresponding with ultrasound to a right breast hypochondrial mass at 12 o'clock with internal vascularity measuring 3 by 1 centimeter. The unit AI detected the mass with suspicion score 53%.
Ultrasound guided TrueCut biopsy was taken and revealed invasive duct carcinoma with medullary-like pattern. The tumor showed sheet-like growth pattern with dense intratumoral lymphocytic inflammatory infiltrate and necrosis. Pathological grade, the tumor was grade 3, DCIS absent, and lymph vascular invasion was absent. Immunoprofile was done, and the tumor ER low positive, weak nuclear reaction in 7% of tumor cells, PR positive, strong nuclear reaction in 2% of tumor cells, and HER2 negative with an included positive external control.
The MDT decision was to receive neoadjuvant chemotherapy followed by wide local excision and sentinel lymph node. Ultrasound guided clip insertion was done prior to the neoadjuvant chemotherapy with confirmatory mammogram. Post-neoadjuvant contrast mammo showed near complete radiological response with marked regression of the size of the mass and intensity of enhancement. The patient was sent for stereotactic guided wire localization of the inserted clip, and it was done through 3D stereotactic guidance.
Histopathological assessment of the grossly detected tumor bed revealed no residual viable tumor cells. Tumor therapy effect was seen in the form of stromal degenerative change, hyalinization, chronic inflammatory cellular infiltrate with hemosiderin-laden macrophage, DCIFs, and lymphovascular invasion were absent. The clip marks the location of the breast cancer. Nodal status, the node was negative with no therapy effect. Final pathological report, invasive duct carcinoma grade 3, post-neoadjuvant chemotherapy, primary tumor T0, axillary node N0, residual cancer burden RCB 0, section margin 3, DCIS absent, and lymphovascular invasion was absent. The question is, low ER breast cancer should be treated as triple-negative breast cancer or as a distinct group? There is an update in the ASCO-CAP guidelines for testing of ER and BR receptors in breast cancer. The original 2010 recommendation was the ER and BR tumor receptor expression was divided into 2 categories, positive and negative. The positive expression is identified if 1% or more of the tumor cells are immunoactive, while the negative, if the tumor is less than 1% of the tumor cells are immunoactive. While in the 2020 recommendations of ASCO-CAP guidelines, A new category is included, the low positive category. The low positive reporting category is applied for samples with 1 to 10% of ER positive expression. However, this category doesn't apply to BR. The low ER expression should be reported in the invasive cancer only, not for the DCIS component. There are limited data in the overall benefit of endocrine therapy for patients with low level of ER expression. They currently suggest possible benefits, so the patients are considerable eligible for endocrine therapy. However, data suggests this invasive cancer are heterogeneous in both behavior and biology and often have gene expression profile similar to ER negative cancer.
The second case, a 40-year-old premenopausal female presenting with at 2019 with an upper outer quadrant mass, nipple retraction, and dimpling. The patient did a mammogram and ultrasound showing bright breast multicentric malignant looking masses with ipsilateral infiltrated axillary lymph nodes. CT chest, abdomen, pelvis showed no CT evidence of metastatic pulmonary hepatic or osseous metastatic disease.
Ultrasound guided recut biopsy was taken and revealed invasive duct carcinoma of no special type with minimal intratumoral lymphocytic infiltrate. Pathological grade was grade 2, DCIS absent, and lymph vascular invasion was absent. Immunoprofile, ER positive, intermediate nuclear reaction in 75% of tumor cells, PR positive, strong nuclear reaction in 30% of tumor cells, while HER2 was negative, with included an external positive control. The MD's decision was neoadjuvant chemotherapy followed by surgery, right modified radical mastectomy in April 2020. Histopathological assessment of the grossly detected tumor bed revealed invasive duct carcinoma, 30% of the same histological type and the same pathological grade. DCIS is present, 3%, and lymphovascular invasion was present. Nodal status, there was residual viable metastatic lymph node deposit with limited therapy effect. The final pathological report, multicentric invasive duct carcinoma grade 2, a primary tumor T2, axillary node N2, positive in 5 out of 10 lymph node with limited therapy effect, residual cancer burden, RCB class 3, margins free, DCIS present, and lymphovascular invasion present. Retesting of hormonal profile and HER2 in residual breast cancer was done in 2 different laboratories, and the case was switched to triple negative, ER negative, BR negative, HER2 negative, was included in both internal and external positive control. So the case is switched to triple negative, while pre-therapy was luminal E.
After 18 months of adjuvant tamoxifen zolitex patient, the patient presented with mild bony aches. CT chest, abdomen, pelvis showed newly developed metastatic D12 and D5 osteosclerotic lesions. The bone scan showed active warring osseous lesions at D12, right sacral piece, likely metastatic lesions. The patient shifted to Zoladex on February 2022, and Zometa was added. Patient again complained of severe agonizing bony aches after only 4 months. Follow-up bone scan on 2022, progression of the metastatic osseous deposit. The patient was referred for possibility of CDK4/6 inhibitor, and it was rejected. So the question is here, when we need to repeat the hormonal profile in ER/PR positive breast cancer after receiving neoadjuvant chemotherapy followed by surgical intervention. In patient treated with neoadjuvant chemotherapy, there is no consensus on retesting biomarker within the excision specimen. CAP-ESCO indication for repeating testing include biomarker histology discordance, small focus, indeterminate or equivocal result, and lack of internal control for ER/PR on biopsy. Retesting of resection tumor can be problematic as false positive can occur cause of prolonged CIT, especially at low borderline biomarker levels. Biomarker conversion of ER/PR and HER2 post after neoadjuvant in patients with residual breast cancer tend to be younger age with worse overall survival for patient converting to triple negative status. The decision to retest in the setting of residual tumor after neoadjuvant should be based on tumor characteristic pre-neoadjuvant and post-neoadjuvant and multidisciplinary discussion. Thank you.
Thank you, Dr. Ahmed Ferdina. Actually, although our session was a triple negative, here in these two cases, we just want to highlight that sometimes triple negative disease present with a typical presentation. The first case was ER low, PR low, HER2 negative, and this is not a triple negative. However, it behaves like triple negative in the with the complete pathological response and good clinical and pathological response. The second case was a luminal breast cancer who received chemotherapy and as a new adjuvant, and then was referred for surgery. The patient started her adjuvant hormonal treatment as a case of luminal, and we didn't retest the marker after surgery. When the patient progressed after 2 years and she was referred for treatment of CDK4/6 inhibitor, approval of the CDK4/6 was declined. And at that time, it was declined because they repeated the ER, PR, and HER2 on the specimen of mastectomy, and that it revealed that it became triple negative. And here we found that we revised the original pathology, and then we revised the pathology done outside our hospital, and we retested again, and we found that actually there was a change of the pathology of that case. And hence we would like to ask how Dr. Abir has highlighted the incidence of receptor change after mastectomy. It's around in the ER cases, it's around from 6 to 26%. And then shall we make it a routine to retest the pathology or not to retest the markers after the mastectomy? Okay, thank you. Okay, thank you.
Yeah, thank you. Just to say that, yeah, in the UK where I work, we are testing all patients, all tumors following neoadjuvant chemotherapy, and there is good evidence for that. Yeah, all cases. There is evidence that this is most useful in tumors that change from negative to positive status, because you will be adding a new treatment.
We do repeat the ER negative tumors after the mastectomy. We repeat the ER. However, we routinely do not repeat the ER and the ER positive tumor. We do not repeat the marker.
Yeah, we do repeat them all, because you will get some change as well. You will get some that change from
6 to 20%. I think cost benefit. This will not add the benefit.
Yeah. So generally you wouldn't withdraw treatment. So you would receive treat on a positive result. So if it was positive before, you will continue as per HER2. But this also gives some prognostic information, because there is evidence that tumors that change profile will have different prognosis. So tumors that change from ER positive to negative behave worse than those that maintain their profile. So for treatment and for prognostic information.
Then if the patient developed a new metastasis, do you recommend to do a new biopsy to retest the marker, or to be treated as a triple negative?
We would generally recommend biopsy if as much as possible, yes. Sometimes it's not possible because the site is not accessible or patient is poorly, but yeah, as much as possible, re-biopsy and retest. Yeah.
Okay. Thank you.
And repeat the
Dr. Abir, if the patient achieves complete pathological response, would it be still feasible to retest for the ER?
Your original pre-treatment biopsy is very valuable, because it could be the only tissue that you have for this. No, if you're happy with the level, obviously somewhere like Bahia, I wouldn't revise it. You trust it, but yeah, if you don't have enough tissue or completely responded, you can't assess again.
So that means in most triple negative breast cancer, we won't be able to revise them.
Yeah, if there is PCR, but if there is residual, even if there is a small residual, we retest. If there is nodal metastasis, you can use a nodal metastasis as well. Yeah.
Okay, thank you. But
Salam alaikum.
we'll start the next session immediately.
Can I ask one question, please?
Yes.
For Dr. Abir. So this raises a question. Do you think how many core we can take? So during our taking, if this is very value, the course before the treatment. What's your recommendation? You prefer to take 6, 5, 3? This is always a debate.
It is. Generally, as pathologists, the more the merrier. The more you can take, the better for us, because we would have a lot to go on. But we normally recommend more than 2 cores. At least, 2 is the minimum, but try to take more. Some places take another core for research or to put it in RNA later or so, but generally for diagnostic purposes and assessment of tumors, at least 2 cores. If you can take 4, that's great.
Okay. What about the gauge? You prefer gauge 14 or 16?
So for standard, mass lesion, 14 gauge is fine. A few for calcification, particularly if you're dealing with, we would go for vacuum, and that's the best. For second line VAP, and we'll talk about this hopefully tomorrow, second line VAP, it's a bigger gauge needle, 10 or 11, but that's if you're treating it almost like a diagnostic excision.
Thank you.
We will start now with the next session immediately, challenges in the management of breast cancer, starting with Professor Ahmed Al-Bastawisi, target therapy in early luminal breast cancer.
ودي ما ينفعش تطلع كده سيدنا عشان ما بشوفش. ممكن في حد يبعت لي ميه. Thank you, Mr. Chairman. My talk is titled BRCA in homologous recombination repair deficient cancers. And this is the outline of my presentation. I will start with a small introduction, and I will go through some differences between germline and somatic BRCA mutation. Again, I will go for some details of testing for BRCA mutations, and finally conclusions. What we know about BRCA and homologous recombination repair deficient cancer, the story of BRCA started in the year 1940 when David Smith demonstrated that breast cancer could occasionally run in families, and we were eager to know which gene is responsible for that. But it took around 50 years, from 1940 up to 1990, until BRCA1 has been identified. And BRCA1 stands for BRCA-associated cancer 1. And then it was identified on the chromosome 17 in the year 1990. And 4 years later, it was then described that we have BRCA2 on chromosome 13. But actually, the landmark improvement in our identification of BRCA genes didn't occur until Angelina Jolie, the famous one, did BRCA testing, and it was found that she has BRCA1 mutation, and she decided to go for a prophylactic double mastectomy. She didn't have malignancy at all, but just she had BRCA1 mutation, and because she had a very bad history with her aunt, if I remember, so she didn't want to go through the journey of chemotherapy, active treatment, because she was keen about the adverse events of chemotherapy, because at that time no new drugs were available, and so the only option was to go for chemotherapy with all its adverse events. So she went into prophylactic double mastectomy. So what we know about BRCA1 is that they are among the first genes which was directly related to cancer, and while they are similar in their structure, however, they are collectively known as BRCA mutation. What we know again about these 2 genes is that we have several types of genetic mutations, rearrangements at the genetic level or even at the epigenetic level. And these changes may result in absent or loss of function of BRCA1 and 2. And we have mainly 2 types. The first one is the point mutation, where we have a single base replacement or removal or addition in the DNA, or we have, as shown in the bottom of this slide, larger rearrangements involving a region, a whole region, and which can be detected easily with next generation sequencing. And we have many well-characterized germline mutations, but again, some may be unique to a single family, which was not previously described in the literature. Again, novel mutations may occur somatically in the tumor itself. But also some clinical consequences of some mutations are not yet understood. They are there, but they are not understood, and they are named as variants of uncertain significance. So the HRR pathway is a major cellular mechanism for detecting and repairing DNA double-strand breaks. And this HRR uses a homologous DNA template to repair double-strand breaks. It occurs during meiosis phase of the cell cycle, where it is activated upon entry into the synthesis phase and the G2 cell cycle. And it is an error-free DNA repair pathway. It is responsible for ensuring that the division of the cells are not in error and not leading to malignancies. What about germline BRCA mutation? It can increase the lifetime risk of certain malignancies, like, for example, breast cancer, ovarian cancer, prostate, and the pancreas. And if we look at the left side of the slide, we know that breast cancer risk is 1/8, which means that 12% of normal populations are prone to the development of breast cancer. However, if we have BRCA mutation, we have up to 46 to 87% probability of having breast cancer. Again, if we have BRCA2, we have 38 up to 84% probability of development of breast cancer. In ovarian cancer, the lifetime risk is 1 to 2%. In normal population, it rises to up to 40, up to 63% if we have BRCA1 mutation, whereas if we have BRCA2 mutation, it is around 17 up to 27%. The numbers are more or less less than that in prostate cancer. We will have a lifetime risk of 6%, but if we have BRCA1, it is 8.6%, and it doubles if we have BRCA2 mutation. In pancreatic cancer, the lifetime risk is 0.5%. Fourfold increase of 2% occurs if we have BRCA1 mutation, and around the 7% probability of catching prostate cancer occurs if we have BRCA2 mutation. What about the differential exposure based on BRCA1 or BRCA2? We have ovarian, breast, and pancreatic cancer. We have ovarian, breast, and pancreatic cancer in which they are prone to the action of to be exposed by BRCA1, whereas BRCA2 mutation is mainly linked to pancreatic cancer. And sometimes we hear that some populations are more have more probability to be BRCA mutant. For example, the Jewish, and why the Jewish are prone to BRCA mutations. Sometimes we have what is called founder mutation, which is a mutation occurring at high frequency in a geographically or culturally isolated population where one or more of the ancestors carried the mutated gene, and that is why the next generation will be more prone to the action of, will be more prone to have BRCA1 population. Ashkenazi Jewish population are a population of Middle or Northern European ancestry as compared to other ancestors in the Jewish population. How to test the BRCA mutation? We have the probability of testing on the tumor samples or to do blood sampling to assess BRCA mutation. And there are some common features for both and some differences for tumor tissue as compared to blood testing. For example, in the tissue samples, we have to go through formalin-fixed perforin embedded blocking preparation, and then we will do processing and the pathology review, method-specific for FFPE, through which DNA extraction occurs, and some common features, for example, library preparation method and the development validation in both blood and tissue samples. And we have next generation sequencing, which is applicable for both samples, and then data analysis classification for the specific BRCA mutation until the final report is released. And this report maybe different in tissue samples as compared to blood samples, because we will have details of sample adequacy and some features of the original tumor in the tissue sample as compared to blood samples. What is the difference between blood and the tissue? Any BRCA mutation can be present in the tumor cells, and this is logic. Whereas mutations in the germline, whereas blood-based testing only detect germline mutations. So testing through the tissue sample has a 50% more probability to detect BRCA mutation. So simply speaking, if you have germline mutation, it can only be detected by blood testing, but tumor testing can detect whether it is blood or tissue sampling. What is the differences between blood and the tumor tissue? Once again, the advantages of blood testing is that it allows identification of germline mutation, whereas tumor-based testing allows identification of both germline and the somatic BRCA mutation. Definitely, blood testing is a non-invasive technique, outpatient procedure. It can be performed at any time, for example, before development of cancer, and that is why it is the basis of assessment of cancer risk in non-cancer patients and in families. It can inform patients and their families about the increased probability of catching cancer, and so they may or may not go through some prophylactic measures. Whereas the tumor-based testing, the samples can be either frozen or paraffin embedded. The biopsies can be utilized for other clinical and histological testing, but some advantages for both. For example, for blood-based testing, we have the advantage of that it cannot identify somatic BRCA mutation. The genetic profiling of the tumor may change with time, and it is not captured by blood testing. Whereas the disadvantage of tumor sample is that we require invasive surgery or invasive techniques whatsoever. Obtaining enough tumor material may be so difficult. Again, even paraffin embedding can result in a loss of DNA quality, and the tumor testing may require parallel blood testing to identify whether it is mutation in the germline or somatic. For example, if we have BRCA mutation detected by on the tissue sample, we do not know whether it is germline or somatic. And if we did blood testing and it is positive, so it is a germline-derived BRCA mutation. Next generation sequencing is a new standard of care, and it is highly multiplexable, which means that we have tumor samples can provide only a limited quantity of DNA for analysis, and the variants can be found across the entire coding region in each BRCA gene. With NGS, we can detect large regions of DNA from a limited amount of input material, which may be typical for the tumor samples. Again, NGS has a high analytic sensitivity because the tumor samples are histologically heterogeneous and yield only DNA comprising a mixture of tumor cell DNA and DNA from normal cells. So if we have a small percentage of tumor cell DNA up to 5 to 10% from the normal background, it can be easily detected by NGS. What about the results? We have a tier of 5 in order to assess the results, where number 5 is a definitely pathogenic or deleterious. Number 4 is likely pathogenic or suspected deleterious. 3 is a variant of uncertain or unknown tumor significance. 2 and 1 are likely benign and benign. So we will have a result of this. And what about the interpretation of the test? If we have definitely pathogenic or deleterious, so the patient is confirmed to have a mutation of BRCA1 and BRCA2, which is described in the literature to be harmful. And we have impact on patient management because we will manage according to the standard guidelines. What about the rest of their family members? It is indicated to go for germline BRCA testing. If the mutation is likely or suspected to be pathogenic or deleterious, so it is deleterious, however, it is not described in the literature, and we again manage according to the standard guidelines. Regarding testing for family members, it is once again indicated. But if we have variant of uncertain clinical significance, so we manage according to the standard guideline, but it is not indicated to test other families. Again, the same for if we have benign or non-pathogenic variants, tier 2 and tier 1, it is not indicated to test the rest of the families. So in general, we have several patient groups in whom BRCA testing should be indicated. Which families and which patients we should go for BRCA testing. Certain types of cancer, for example, if we have ovarian, pancreas, prostate, and breast cancer, all these cancers are known to be linked to BRCA mutations. So why not to test for the BRCA especially? We have now many standard treatments in patients who are BRCA mutant. Again, if we have a strong family of cancer, particularly young onset disease, for example, breast cancer, median age is 65, ovarian cancer in the same range, the median age of around 70 years. So if we have a younger population, if we detected breast cancer or ovarian cancer in a family in a younger age than that, so we have a more probability to have BRCA mutation. If we have history of prior cancer, if we have advanced or aggressive disease, and as I said before, if we have certain populations like Ashkenazi Jews, we have a founder mutation, so it is recommended to go for testing of BRCA mutation because we have a more probability of having a BRCA mutation. On the individual level, when we are testing for a certain gene, so every patient has the right to test for the probability of having a gene or not, but if we are doing the testing on a nationwide, for example, database, we should weigh the benefits against the cost. So when we do that test, we do it in the more prone populations. So, and if we have a patient with BRCA mutation, we have a standard treatment now in several malignancies, for example, ovarian cancer in the maintenance regimens and in the salvage regimens, again in breast cancer in the adjuvant setting, as I will discuss shortly in another speech, and for example, in pancreatic cancer. So several malignancies, we have many drugs which are now playing in BRCA mutant populations, so we should go for testing of BRCA mutation in the prone population. NCCN guidelines, for example, recommend BRCA testing for individuals with a BRCA-related cancer because they may benefit from genetic testing to determine eligibility for targeted therapy. Again, these mutations are predictive of sensitivity to old class of drugs like platinum agents and a new class of drugs which are PARP inhibitors, and this is simply because BRCA mutant populations are deficient in the mechanisms of DNA repair, and that is why they are prone to the drugs which are DNA damaging, like the old class of platinum and the new class of PARP inhibitors. So genetic counseling, what about genetic counseling? It means in, for example, families of cancer patients in normal populations, which are not cancer patients, it is recommended but before testing, the patient must understand the implications of the testing. For example, if we have if we have a BRCA1 mutation and we have 80% probability of getting breast cancer in life, if the individual is not psychologically stable, he may be under severe stress. And it should be discussed very thoroughly with every individual before going for the testing. It includes family members of cancer patients, especially the previously mentioned malignancies, because this may help to understand the risk and the available options, like, for example, prophylactic mastectomy, as Angelina Jolie did. So in conclusion, BRCA1 and BRCA2 were among the first genes whose mutations was directly linked to cancer, and they remain two of the most studied genes in the disease area. And the mutations can be of several types, from single base alterations to a large genomic rearrangements, and can be germline or somatic. Some of them are well characterized, where others are of unknown significance. Mutations of HRR genes, including BRCA1 and BRCA2, can lead to HRR deficiency, which can increase genomic instability and makes the patient sensible and more sensitive to PARP inhibitors. Again, germline BRCA1 mutations increase the lifetime risk of many malignancies, and certain cancer favor either BRCA1 or BRCA2 mutations, and the prevalence of BRCA1 also varies according to geographical or according to the ethnicity. What about testing? Blood and tumor testing for BRCA mutations have many steps in common. For example, blood tumor testing has additional processing steps not required for blood testing. And despite advantages and disadvantages of each technique, only tumor testing can detect both germline and the somatic BRCA mutation. NGS has become the preferred method of BRCA mutant detection, and it is capable of using very small tumor samples. Once BRCA testing is completed, healthcare professionals receive a lab report, and the BRCA mutation can be classified on a 5-point scale from 1, which is non-pathogenic, up to 5, which is definitely pathogenic or deleterious. And the clinical trials, for example, include 5 and 4. For example, the Olympia trials include patients with tier 5 or tier 4, which are known pathogenic or suspected to be pathogenic. There are several patient groups, like, for example, Ashkenazi Jewish people for whom BRCA testing is strongly recommended, and the results of the testing can be used to inform treatment selection. And finally, genetic counseling is an important part of genetic testing process, and it can help patients to understand the implications of having a BRCA mutation for their disease progression and inform family members of their potential risk. And with this, I thank you for your attention.
Thank you, Dr. Ahmed, for your excellent presentation. As usual, the floor open for any question. No question? Okay.
Okay, thank
Our
you.
session. Okay, thank you, Dr. Ahmed, for your excellent presentation. Okay, thank you for our speakers and our audience. The session will be closed. Okay, thank you.